Dear colleagues, welcome to the EASL Studio, your weekly hepatology broadcast news. Today's episode is linked to the Journal of Hepatology and is dedicated to the terminology of compensated cirrhosis and compensated advanced chronic liver disease, cACLD. The term cACLD has been introduced by Baveno-6 in 2015 and reaffirmed by Baveno-7 in 2022. In the last paper, both terms, cACLD and compensated cirrhosis, are defined as acceptable, but not interchangeable. This sentence is very clear, but its declination in clinical practice is not clear enough. So the purpose of the episode is to push the discussion into a deeper level. To do this, I have invited three outstanding experts in the field, and I want to welcome them to the episode. Professor Guadalupe Garcia-Tsao from Yale, Professor Valérie Paradis from Paris, and Professor Thomas Reiberger from Vienna. Welcome again. So all of you know that cACLD is based on liver stiffness. Now, just to start with the biggest question, in clinical practice, ultrasound signs, for example, or other imaging signs are used to make a non-invasive diagnosis of compensated cirrhosis. So my question is, do you think that nodular hepatic contour, change in volume distribution within the liver, enlarged caudate lobe, an atrophy of the right lobe, and parenchymal nodularity are enough to move from cACLD to compensated cirrhosis? Or we need a liver biopsy to do this change?
So I guess I can take this one.
Yeah.
So I think when we see these patients that have a shrunken right lobe, big left lobe, splenomegaly collaterals, this patient has cirrhosis. We don't need a fiber scan. We don't need a biopsy. This patient has cirrhosis, and it should be. And if the patient doesn't have ascites, encephalopathy, or variceal hemorrhage, this patient has compensated cirrhosis, right? So that is, and now you may have a patient with chronic liver disease, and morphologically there's none of these changes, but however the liver is stiff. This patient has cACLD, right? It meets the criteria for cACLD. If sometimes there may be doubts or there may be indeterminate or whatever, then we would sometimes go to get a liver biopsy, and then liver biopsy is still going to be our gold standard. But if the diagnosis is made through biopsy, and Valérie can comment on this, is then if there's nodules that are surrounded by fibrous tissue, the patient has cirrhosis, independent again of what the fiber scan showed. cACLD is a non-invasive way of assessing whether the patient has advanced fibrosis or cirrhosis.
To go ahead, maybe as a pathologist, I can say that at the very beginning, when we go back to the Greek period, cirrhosis was used to define abnormal architecture of the liver. Cirrhosis means tawny, firm, and nodular. So if we want to diagnose cirrhosis, we should use morphological exams. But since now we use more and more non-imaging approaches, I think it's really legitimate to move from the terminology of cirrhosis to cACLD.
And Thomas, what do you think?
I think the concept of compensated advanced chronic liver disease is a modern and recently defined that is really summarizing the modern concept of risk stratification. Because we have learned that the liver stiffness, so the mechanical property, is not only correlated to histological fibrosis stage, because that's what we used it in the beginning. So we always wanted to know which patient with hepatitis B or C we should treat. And it was always correlated, the liver stiffness value with the respective fibrosis stage. But then we learned that it's actually a risk that we can measure with this. And it's not just this semi-quantitative way of putting patient in different fibrosis stage categories, but to assign a certain risk, and that's the clinical relevant thing, for liver-related events. And this is, as we know, decompensation, most prominently ascites, hepatic encephalopathy, and variceal bleeding. And the main advantage that I see is not only the connection to this prognostic factors that I just mentioned, but also to transport it to patients and to other colleagues that it's a very dynamic disease. And with cirrhosis, it was always seen as a kind of end-stage disease for patients and also for physicians. But we learned so much over the recent years, and we could see that this is changing with etiological treatments. And I think this is the main advantage, that we can also transport our very, very important scientific observation that fibrosis is not always progressive, it can be regressive, but this translates into the risk of events, which is the clinical relevant scenario that we want to prevent in many instances.
So
We will develop, sorry. Well,
I just want to make a comment because I don't agree that we should do away with the term cirrhosis. I always tell my fellows and everybody that patient's going to have surgery or the surgeon's going to actually see the liver. You know, you go back to the note and see if this was a non-retrangular. This is a cirrhotic liver. This is cirrhosis. We're not going to call that cACLD. This is cirrhosis. If you see a liver on imaging and you see collaterals, you see splenomegaly, this patient has cirrhosis. Now, if now you're doing it non-invasive, and I totally agree with Thomas. Now not only does it help us tell if there's advanced fibrosis or cirrhosis, but the FibroScan, the transcranial elastography, also the stiffness of the liver also lets us know whether the patient may or may not be at risk of decompensation. This is something that perhaps morphology would not have helped us at, right? So this gives us a further characterization of the patient in that this patient is going to be more likely. On the other hand, if the patient with imaging with a cirrhotic liver has collaterals, I don't even do it for this patient has CSPH, has clinically significant portal hypertension because the collaterals have open, which implies that just by virtue of having collaterals, this patient has CSPH. So there's different levels, but I think that is very useful to figure out how you made the diagnosis. If this is a cirrhotic liver or is this a non-invasive way to indicate that the patient has advanced fibrosis or cirrhosis.
So may I summarize what you said, saying that a non-invasive diagnosis of compensated cirrhosis is still possible on the basis of imaging? Okay.
Yes.
Well, said this, I want to know how the change of terminology from compensated cirrhosis to cACLD has changed your clinical practice. For example, do you think that the use of cACLD may favor referral, may increase the referral, reducing, for example, the stigmatization related to the use of the terminology of cirrhosis that in some country is strongly related to the abuse of alcohol, And how do you change the follow-up according to the terminology? Is it different in patient with compensated cirrhosis, in patient with cACLD?
I can start.
We follow the same order.
Okay, awesome. So I think, yes, having the term compensated advanced chronic liver disease takes away some of the stigma. In the US, if you say this patient has cirrhosis, everybody immediately thinks this is either alcohol, hepatitis C, they got it through, unhealthy, behaviors. So that would take away the stigma for sure. In terms of referral, I think we've been doing, referrals may be the same, but we definitely are doing much less liver biopsies, like significantly less liver biopsies when we know what the etiology is, when we know that when our main goal is just to determine whether the patient has advanced fibrosis or cirrhosis.
Valérie?
I fully agree. We see much less biopsy regarding this this moving on terminology, for sure.
And Thomas?
Yeah, in our hands, it has also massively impacted clinical practice and also referral strategies. However, it depends on the availability and on the confidence the examiners have with the non-invasive method. We know there is transient elastography with most evidence out there, and RF-based techniques are increasingly used, but there is also expertise needed for that. And I think in an ideal world, with the ideal test, this would massively help to channel healthcare resources, because you know which patients you need to see at the secondary and a tertiary care level. And on the other hand, from the academic perspective, we learn a lot about the natural history of diseases. And this has been evident because in the beginning, we have used elastography mostly for Hep C, viral hepatitis, and alcohol. Now more and more data are also become available for rare diseases, and it's clear that it's reasonable and useful for all types of liver disease. I think the main issue is now to transport this to the wide community that is a little bit outside of the hepatology bubble. They need to understand what we mean when we say compensated advanced chronic liver disease. And there we have a message to transport. We need to be clear with what we speak about, that this is a risk-based concept, and what is the consequence, and which type of compensated advanced chronic liver disease patient still needs care at the tertiary center, because there's also risk of portal hypertension, and which patient can be seen in secondary care or even can be discharged in primary care. So the concept is really, really strong, but we still need to educate the full field even outside the liver world.
And if I can add something, you know, and you hit it on, I mean, this is something that is also operator dependent. You know, I think that in Europe, as the hepatologist that's doing the transient elastography, in the US, we have technicians, we have nurses or that are doing this that may not be as invested in doing this or getting it. So in my center, for example, I interpret all the files. So I look at the tracing, I look at the variability, I see if it's a trustworthy scan. Then I look at the patient's chart and see if it's consistent with the clinical picture. And if there's any discrepancy, we may still end up doing a liver biopsy, for example. But I think it's very important to understand that, and we don't know about other machines. I mean, unfortunately, we just have the one transient elastography machine, and we would like to know if the same cutoffs apply to other devices. And I would like to hear, you know, what Thomas has to say about this, or Paolo, because right now we're sort of bound to this device, and in some ways it is somewhat operator dependent.
Maybe there is also a need for identifying predictive factors of prognosis of patients who will present complication, and maybe at that time we will need to go back to liver histology, because we know that we can have some features associated with progression or with regression. And now with the input of AI and so much computational approach applied on imaging, maybe the liver biopsy will be in the future more useful if we are able to develop such tools as we do, for example, for tumor biopsy. So maybe the biopsy is not fully dead, and in the future, we can work on that predictive factors.
This will be great. So going to one of the points that Thomas highlighted before, cACLD is aimed at stratifying the risk of decompensation, no, related to clinical significant portal hypertension. So according to the Vaveno 7, we should start the prevention of decompensation in patients with liver stiffness higher than 25 kilopascal, or in between 20 and 25 with a reduction of platelet count. is this option, can be disseminate this option in the clinical practice, not only in secondary tertiary center, but also in more common hospital? Or this is an option that we should reserve to secondary or tertiary liver centers? What do you think?
Well, I think this is center dependent in a way because, for example, here we have the machine in hepatology, so they have to refer the patient to us to have the measurement done. I don't know, like I said, it's not just you get a number like you had the blood pressure. It's a number that has to be taken in the context of the patient. So it's always better to have someone that is looking at it. I would like to hear, what people in Europe are doing, because we have it here. We are not doing the thyroid scan. We have a technician that does them. And in patients that are referred to us or that we call from primary care that have abnormal liver enzymes and may have mast cell and want to stratify risk, we call them here and have the thyroid scan done here. So primary care is definitely not doing this in the US.
Thomas, what do you think?
So I actually want to summarize again what you said. Paolo basically summarized the non-invasive criteria, Baveno criteria to diagnose clinically significant portal hypertension based on a single transient elastography value above 25 kPa. To be very specific, the evidence is strong for hepatitis B, C, alcohol, and non-obese MASH. For the other etiologies, the data are not yet that strong, and potentially will be available in some weeks and months from now. And so, if we can have the non-invasive diagnosis of CSPH, and as soon as CSPH can be diagnosed, a non-selective beta blocker treatment should be started based on the evidence that we have from the Paradis study. Caveat here: the Paradis study was HBG driven, like the whole concept of CSPH.
Yeah.
Now, if you ask me personally, I think in a compensated advanced chronic liver disease patient starting carvedilol, you don't do any harm. I think it is a very safe drug, and it can prevent a lot of morbidity and even mortality, as some individual patient data meta-analysis have been shown. And so I would not be scared to initiate a non-selective beta blocker, specifically carvedilol, in a cACLD patient that has a very high likelihood of CSPH. And the point that I want to make about using non-invasive tests is that you don't get just a yes or no. You get a probability, and there have been anticipate models, but also other models that just don't give you a yes or no, that give you a probability, a likelihood. And I think that's how we should best use our non-invasive tests. And if you, for example, have a FibroScan that's not just 26, just hits the threshold, but you have a FibroScan of 37, 40, and you can still consider your clinical judgment and the clinical laboratory parameters that you have, and platelet counts you also have available, you can be very, very sure that your patient suffers from CSPH, and then I would go straight ahead and treat with carvedilol to avoid mortality.
Do you think that non-invasive way will be also possible to be used to monitor the effect of carvedilol in this patient? Because this is an unmet need that we have in this field, how to monitor the effect of the drug on portal hypertension in a non-invasive way. Otherwise, you will wait if the patient will decompensated or not to define the patient responder or non-responder. That in the era of precision medicine is something a little bit unacceptable,
Yeah. If I answer very quickly, liver stiffness is very likely and most likely not the best tool to do that. Spleen stiffness is promising. We will see the data soon presented in Milano. And on the other hand, I think there will be parameters that can form a compository score where we can be more sure that a patient will benefit from a non-selective beta blocker. And we have learned that this is not only hemodynamic effects, so they have also effects on bacterial translocation, and so on. So I think there will be markers, but liver stiffness is not the way to monitor a beta blocker response.
I would agree entirely with that. But not only that, even if we had HVPG, Juan Alvarez showed in an incredibly elegant study that individual changes, as opposed to when we do the studies, it's a group. He did of all the studies that had initial and last HVPG, he showed that by groups, yes, in fact, the placebo group does not change as a group, but in the individual patients, you have variation. So the bottom line from this is that you don't count, you're not gonna, it's not like measuring arterial blood pressure. You start the carvel and you're not going to look at a response because it's going to be false in a significant percentage of the patients because you're taking just a time point. So I think it's not useful, but even if it was, even if the spleen stiffness is in fact correlated with the HVPG, it's going to be in a group thing, not an individual basis.
Do you think that omics may be useful in this setting, for example? Because up to now it was not useful, but I'm very optimistic about the result of omics in this field because omics will take into account several drivers of decompensation, not only portal hypertension, you know, but also bacterial translocation, inflammation, and so on. What is your vision on this? Are you skeptical?
I'm skeptical.
We can expect that.
I'm a skeptical person.
We can expect that omics that you can quantify in the blood of patients should be good indicators. It probably be combination of different markers. I don't believe that only one marker will be enough performance to evaluate such response, but extracellular vesicles, so different kinds of molecules can be quantified in the blood. So we have to be optimistic.
And
I'm more optimistic of the combination of spleen and liver stiffness and not only just to better characterize risk, for example, but I think also now that we're into recompensation, regression, and so forth, this company would probably be more useful to see who with hepatitis C that's cured will be, you know, zero likelihood of decompensating. And this regression is probably better assessed with a combination of liver stiffness and spleen stiffness. That is what I think is fascinating. I don't think that with drugs we can get that granularity, but with gross things that are happening with the liver, like regression of fibrosis, this would be something that would be very fascinating to me.
I'm quickly saying I'm a believer. So I like what the omics technology have already taught us and will teach us. And maybe I can quickly go back to the comment of Valérie. She said that liver biopsy, we might go back to that. And in this regard, I want to mention spatial transcriptomics. And there have been amazing data, also just recently published in JHEP on spatial transcriptomics in PSC, and there is only one disease where we can learn from that. And I think this is not the last episode on liver biopsy that we have probably had. I'm really looking forward what the omics technologies have for us in the future.
Thank you. So the time is running. And I will go to the last question. You mentioned the several time regression. That is a big point around which there have been up to now a big debate. So the distinction between cACLD and compensated cirrhosis can help the resolution of this debate in the sense that cACLD probably can regress more easily than compensated cirrhosis. What do you think about this?
I think that what is important, I think, is not so much to say is cirrhosis or cACLD, is can we non-invasively identify those patients who do no longer require beta blockers because their CSPH has resolved. So that is the main thing. At what point am I safe to stop, giving when we discontinue the beta block, for example? That would be the main thing. And obviously, I guess we're not gonna, if we could measure the HBG, then that would be the key, right? But that it's not feasible. So I think we have to find at the appropriate threshold. That's where I'm saying that probably a combination of the spleen and the liver would be a much better marker of when we're safe to discontinue the beta blockers. Then about regressing to and that's the only thing, because in a way, I think that until we show that there's really a threshold that will prevent HCC from developing, these patients that at one point have cirrhosis, I think they have to be screened forever. But this is something that would require, further investigation.
Valérie.
In fact, that some cases of cirrhosis may regress when they are at the beginning of the story of cirrhosis, when the fibrous septa are much more edematous with inflammatory. And if you can control the activity of the disease, you can observe some degree of regression. And on the biopsy, we can see that, because we can see that the septa are maybe discontinuated, they are perforated, and it's a very good sign of regression of cirrhosis.
But do you think
cirrhosis may regress?
But do you think they are still at risk of HCC or not?
I think they can go further to HCC also.
Yeah, that's the whole thing.
Yeah.
Thomas.
So in my clinic, which is even called cirrhosis clinic, so all the patients, they come in and they know that they have cirrhosis.
Oh man.
We scan them with transient elastography and other RF-based techniques every 6 to 12 months. And here's the thing: the patient, they don't ask me, do I still have cirrhosis? They just ask, did it get worse or did it get better? So I think some of these patients, those who underwent these elastography techniques already quite often, they already ask the right question. So where is my direction going? What's the trajectory of my disease? And I think that's the beauty of these non-invasive things. You repeat them. They wouldn't do the biopsy every 6 to 12 months, but they actually ask for the elastography. And there will be a lot of data on the dynamics of liver stiffness and likely also spleen stiffness that will reflect the course of the patient. And I'm very confident that this is an extremely powerful tool next to the omics technologies.
So Thomas, can I ask a question? Because I'm also fascinated by these changes and so forth. But we have, and we're looking at this. Does weight loss have a change just by losing weight in these really? We're now faced with MASH. Does changing a weight change the FibroScan, change the liver scan?
In the very, very obese patients, especially the ones bariatric surgery where it drops very, very rapidly, it has a huge effect. But those like lifestyle intervention, that is diet and sport, it not always has. If it has, I think it has a really biological meaning, and we should also look for that. Patient even ask if there is an improvement, as I said before.
Thomas, let me to be a little bit provocative. I agree that repeated FibroScan is useful to decide the direction in which the patient is going. But if you have a patient that after an etiological treatment move from 25 kilopascal to 9 kilopascal with normalization of liver function test, what do you say to the patient? You still have a compensated chronic liver disease, or you will say to the patient, well, you recovered completely from compensated chronic liver disease?
He does a biopsy.
Well, if the patient is up for academic studies, I would actually encourage that, to see what's happening. But I can tell you what I'm not saying. I don't tell the patient yet you are cured from cirrhosis. I tell the patient, congratulations, it seems like you have a significant improvement. The same thing that I do with the first time a result that is going in the wrong direction, I would like to confirm it potentially by an independent test. But I think a confirmed improvement in a valuable non-invasive test like transient elastography has a strong meaning. And what we would potentially use that the patient has regressed to a non-ACLD stage. And the other thing that's important, the patient could still have cACLD, but the patient might have resolved CSPH. And that's also one of the features that can be identified by repeated non-invasive testing. But there's more data and evidence that need to be created before we can really be sure about the recommendations, such as stopping beta blockers.
Okay, guys, thank you very much because our time is over. So I want to thank you. I want to thank all the colleagues that attended our meeting. You can see again this episode and other episodes connecting yourself to the EASL Studio. And said this, please join us next week for an insight exploration of alpha-1 antitrypsin deficiency as leading model for the development of genetic therapies. Overall, I want to remind you to become a member of EASL and join the great EASL family. Thank you very much again. Bye-bye.
Thank you.